Hello, everyone. Can anyone hear me? MR just gave me a thumbs up. Okay, so I assume, perfect, everyone can hear me. Are you guys muted? Um, just want to make sure you guys can. Okay, hold on a second. I'm going to try to unmute all of you.
My mic is working now, thanks.
Oh, perfect. I'm not by myself.
Hi guys, how are you all? Chad here. So I just thought I'd just do a quick introduction and just get everyone sort of orientated. So Joe, I see the video's off. We can't do video, but if we could, we can maybe, but it's fine if you can't.
I'm going to work on that.
Okay, cool. So guys, welcome to the first clinical or the start of the clinical training aspect of it. So Joe, the first cohort, these were sort of some of the real early adopting doctors. We allocated them into the first cohort because they really were sort of standout. We had just completed 2 weeks of business boot camp, and last week was sort of said to be a bit of a practical week where they had to go chat to some GPs, sign up to the virtual platform, get some patients on. That's an ongoing thing that they're going to be doing throughout. So now we're shifting into the clinical side of it. So just for some context, everyone, Joe will give some more detailed background on who he is and so on. But Joseph and myself have been working together for a good number of years. Joseph is probably the leader, if not one of the leaders or one of the biggest. Actually, yeah, he's probably the leader when it comes to point-of-care ultrasound on the continent. We've done a lot of work in various countries. Joe's been driving focused training across sub-Saharan Africa and Kenya, in the US, various territories across sub-Saharan Africa. And he really is the go-to guy when it comes to focus. And we've been building a good relationship over the last few years. And when this initiative came to be, it was very much sort of a no-brainer for me to bring Joseph and the team in. So they've got an entire team in the back end that has really built some of probably most of, if not all of, the focus curriculums in this space across sub-Saharan Africa. And it's an absolute privilege for me to have him, working alongside us and doing the training with you guys. So he'll be sort of running, and his team will be doing the clinical, which will be the combination of these webinars and all the material you guys will be engaging with on the LMS is from them, as well as a certification. And then they'll also be running the in-person sessions with you guys. So I know the first phase was very business orientated and a little bit, I think, more, I guess the word is, new to a lot of the doctors. This is a little bit more familiar to a degree. But Joe, we just need to continue sort of the undertone of how this is going to be positioned from a commercial standpoint when they go into the market. Some of these doctors on here were the ones that suggested the MSK stuff, like I spoke to you about. I think it was Mikhail and I think Tegan, mentioned it, to maybe, introduce some basic MSK. Because again, the main goal is that these doctors are going to go out into the market and offer focus services, which are currently not being offered to the market. So, I think that's really sort of just to keep in mind as we go through it. We will also do, guys, a session on the clinical side of it when it comes to the virtual care side of it, that's a little bit different. But Joe and the team are solely focused on the poker side of things. So Joe, I think, yeah, that's just a brief intro. The team, this is an amazing group of doctors. I think, I know you know how passionate we are about what we're trying to achieve here. And, guys, we're actually looking at similar models in other countries. And you guys really are sort of really pioneering doctors, that the ones that have jumped onto this. So yeah, so Joe, I think maybe take the floor is yours. I'll be here in the background. I'll just chirp in here and there when it comes to maybe just the first few sessions are going to be a bit very much didactic in a way. Not didactic, but just like fundamentally orientated. So just for context also, you can check with them, but it wasn't a prerequisite for the doctors to have focused experience per se, but 99 all doctors have some form of ultrasound exposure during their internship and commercial. So yeah, but you can take this.
Perfect.
My brother. Thank you.
Perfect. Thank you, my brother. Thank you. When Chad came to me and said, "Hey, let's do this. Let's train doctors," I was like, "Dude, you're talking my language," because for about 35 years now, I've been involved in the ultrasound field in some way, shape, or another. I did high-risk obstetric when I was in the U.S. In the Caribbean. I've trained doctors in how to do fetal echocardiograms, how to diagnose some really bad things when it comes to tropical diseases. Working right now actually with the Kenyan government in shaping their HIV POCUS program. So my experience is kind of broad, but at the same time specified to ultrasound, because I just see this vision that I have in my head, and Chad kind of shares the same vision, that if we could just teach non-radiologists, non-sonographers, non-obstetricians to do proper ultrasound, how many more lives could we save? How many more things could we find that we're not finding right now? I know in East Africa, we're finding out that those rural doctors that are now learning to do ultrasounds are picking up so many different things, and they're actually increasing the business of the radiologists and the obstetricians around them, because they're sending them these cases that they're like, I don't know what's wrong with this placenta. And it turns out the placenta, is not only previa, but it's a vasoprevia. All the placental arteries are right in front of the cervix. So I say that to say this, guys. You guys are amazing for wanting to do this, first of all. You guys are amazing for actually taking the time to say, hey, we want to learn a little bit more than the regular person knows. Point of care ultrasound is very specific. It's point of care, right? It's a bedside ultrasound. It's an ultrasound that is going to allow us to give quick answers. And that's actually the thing. Point of care ultrasound requires that you give me a quick answer. I don't need a specific answer. I don't need you to delve into it. I don't need you to be a sonographer. I just need you to tell me, is this normal or is this not normal? And if it's not normal, do you have a right referral pathway? Now, Chad had said that some of you have ultrasound experience, and I don't want to just talk this whole time, because there's going to be time for lecture. You and I will meet each other in some weeks when we do the hands-on. But those of you who anybody that has ultrasound experience, please holler out to me and tell me what experience you have. What have you been doing? What did you do with it? Chad, do you have any idea who has the experience on this?
So yeah, when we did the sort of recruitments, we just asked if anyone did have, and some had, some didn't have. But the only experience I had, just from my side, was in my my first day on call in my internship, and I had a patient come in MVA with a fast. My consultant said needed a fast scan, and I had no cooking clue how to do fast scan. Ended up going, and also didn't have equipment in the hospital to do it. So I ended up going on YouTube, and that guided me through my fast scan. And then I think in internship, I think this is universal. You just kind of do the obstetric stuff. You do the in the wards, you get a bit of exposure. But yeah, I think that's really sort of baseline that I think most of the doctors got exposure to. But yeah, the others, I'm not a clinician anymore, so I can't really say anything. But yeah, the others should have.
Yeah, you and I are in the same boat. I don't do clinicals anymore, and I think that I'm I'm a little better person for it because I did, been there, done that, and so now I see myself on this end of it, on the training end. And when I went through school, I didn't get a lot of exposure to ultrasound. Ultrasound was basically, it was like the Ark of the Covenant. It was a holy grail. Nobody could touch that thing without express permission, and if you touched it, you're in trouble because either the technologist or the resident would get on your back. Why did you touch that? Why did you mess that up? So I think that it was considered at the upper tier, only obstetrician residents and radiology residents touch those things. Now we're finding out that we should have gotten the knowledge in ultrasound. Now we're finding out that doctors and nurses graduating from nursing school and medical school need a basic understanding of how to use that. Before I delve into this lecture, one radiologist asked me actually it was here 2 years ago when we started training for ultrasound here. He said, "Why are you teaching people to do ultrasounds? That's a radiologist's job. That's a sonographer's job. We don't want anybody out there using an ultrasound piece of equipment to make diagnosis." So I very carefully thought about my words, and I looked at him and I said, "But when you went to medical school, they gave you a stethoscope. And when you left medical school, you still use that stethoscope. Does that mean you're a cardiologist?" No, it does not. It means, and he looked at me like, wait a minute, it just means that now you have the capability to listen to a heart and to say, you know what, something is wrong here. You need to go to a cardiologist. Yeah. And that is the same thing that we're doing with point of care ultrasound. I don't expect you to be sonographers or sonologists or obstetricians, but I expect you to know when something is not right and when something needs to be referred, and to have established a good referral pathway to make sure that that patient goes to where they need to go. So in saying that, I'm going to jump into this. Go ahead, Chef.
Karina, sorry, your hand was up. You wanted to say? Karina's hand was up, sorry.
It was nothing big. It was just to contribute ultrasound experience, but I feel like we sort of carried the team there, Chad. Thank you.
No, I'm done talking now. That was my only, just to introduce Joe. But what was your experience, Karina?
I was going to say, I think I've been quite lucky. Well, during med school also got taught absolutely nothing. But then during internship was lucky enough to have seniors that sort of directed us toward ultrasound courses and wanted to show us things. So I've done a basic course, but no accreditation. And then in my second year of internship, there was a initiative between, I think it was a German university and UCT that offered a ultrasound course to interns in the area. But yeah, that's sort of the continuing assessment and everything doesn't really happen. So you get taught these skills and then you go back to your hospital and then either you don't have an ultrasound machine or no one lets you use the machine. So yeah, it's a bit of a challenge.
That's good. And I think it's an important thing to sort of highlight there is that the market itself, when it comes to adoption of ultrasound, and obviously point of care ultrasound being like Joe says, at the bedside, it's an extension of your diagnosis. It's there to help you identify early, screen appropriately, and what's for me is very interesting is there's a big difference between public sector and private sector applications and how POCUS fits into it. And obviously we are moving and into the private sector side of things, where we need to identify opportunities where point of care ultrasound can be used to enhance that patient care and also to improve that patient's disposition, which is obviously how soon they get appropriate referral. And I think that's a very important thing to keep in mind as we go through it, and as Joseph and the team go through the training, is to think, okay, we are obviously going to be focusing on common primary care related stuff, which is stuff that will most likely allow you to generate an income from scanning where we're operating. And I think it's just very important to keep that in your mind. Think about the canvas we created, the customer we're trying to service. In our setting, Joe, we're going to be selling these services to the GPs and to existing hospital infrastructure I actually had a discussion with one of the doctors in the cohort last week, who just recently managed to form a partnership with a local clinic, like a state clinic, to offer HIV services to them, as in seeing the patients. And we were just high level discussing, how do we position Focus as a service to the state, right? Because Joseph worked with me on Unjani, which I think I mentioned to you guys previously, the nurse-led community-based network of nurse-led clinics. And ultimately, state patients are now using Unjani clinics for their ultrasounds. And I see your comment there, Mohammed, about the sonographers. They are the challenge is that there are not enough sonographers, and also sonography shifts ultrasound beyond the bedside and shifts it to the specialist investigation realm. So our whole mandate is to move ultrasound from a specialist investigation or to a bedside investigation, almost, if that makes sense. So finding opportunities within the primary healthcare setting where we can introduce Focus as a mechanism and as a means to improve patient care. So I think just wanted to give that sort of framing so that as we go through it, it's going to be a journey. But I think between myself and I think Joe being at the forefront of really getting Focus as a construct adopted, at the primary care bedside level, we're just going to learn a lot as we go along, and it's going to challenge some frameworks, I think, because I think common things that come up is like, and I think especially with doctors, there's this thing about, if I'm not fully certified, can I do it? There's a confidence issue with regards to the scanning.
Yes.
And that's really frameworks we want to break down and really get past it, because I think that the market is in desperate need of the service. And, you guys are the primary people to deliver that service.
Yes, 100%, Chad. But Chad, can I ask you a question? Mohammed, let me ask Mohammed a question. Mohammed, you said that the state is in desperate need of sonographers. Why do you think that? I want to challenge that. Why do you think that? I know Mohammed is on here because I just saw him.
No, he is. Too many patients, not enough sonographers. Fair?
Too many patients, not enough sonographers. Okay, so I'm going to challenge that a little bit. And Chad said we're going to challenge the status quo in this training. I don't think we need more sonographers. I don't. Yeah. I think we need more specialists that can do sonography, right? It's just like saying to me, if you don't have enough transportation, we need more public transportation in Joburg. No, we just need people to learn how to drive better, basically. Right. And so I think that if you look at the whole sonography business, look at the way that Australia, that Europe, that the United States does sonography. They do it in a highly specialized field. So an echo sonographer does not do vascular in the United States. An obstetric sonographer does not do echo. So it's very highly specialized. So I think that we now have the opportunity to become specialized and to use our general practitioners to actually upskill people, to train them to do sonography instead of asking for more sonographers. Because I don't think this economy can afford more sonographers, to be honest with you, because they're basically too restrictive and too highly paid and not regulated enough. Mohammed, I think I just heard you come in. Let's see, his mic is off. Yeah, there it is. Okay, so if you wanted to comment on that, Mohammed, please feel free. But I don't think we need more sonographers. I just think we need people better trained to do ultrasound, which is exactly what this program is seeking to do, is to train us to do better ultrasounds, to train us to know what it is that we're looking for, right? So, and I think that who better to take this than the doctors like you that are at the forefront of this, right? And Mohammed, you asked to be unmuted. You are unmuted. Your mic is not on mute. You can speak.
Hello.
Yes, we can
Hey,
hear you.
Mohammed.
Hi, can you hear me?
Yes,
sir.
very well.
Oh, that's strange. Okay, no, it just says I'm muted over here. Yes, so let me just give you a quick background of me. So, in my community service, I actually rotated through radiology. So then I've got some ultrasound experience in doing in
Excellent.
all the different fields. So the thing was, we had to do all the ultrasounds, whether it was MSK, cardiac, renal, abdomen, pelvis, you can name it. Basically, we did everything.
Yes.
So we used to have a sonographer, but the sonographer complained that there was just way too many patients. They couldn't handle the workload. And there was only one sonographer for the entire hospital. So we managed to
Wow.
fill that gap, you're right, with what little experience we did have at the time. So I think
And
it's
you
a
filled
good
and you
idea.
filled the gap. And the thing is, like Joe will tell you, he's got sonographers they all work for him. There's not enough sonographers being graduated, number one. And also the way that the industry is structured, and by industry I mean public and private, and then the commercial models behind the two. There will never be enough sonographers because, again, like you experienced, they will only employ one sonographer, and then that sonographer needs to operate across the board. Some nice, better hospitals or better equipped hospitals maybe have 2 or 3, and then for obstetrics, that sonographer will only do obstetrics, etc., etc. But also how it's funded within the government sector is very different to the private sector. So in the private sector, you end up with sonographers who operate under radiologists because radiologists can charge more for scans as specialists. So then they will charge maybe 5,000 rand a scan. They pay the sonographer maybe 750 for that scan, and the balance is profit for the radiology business, because obviously the radiologist business can charge more as per medical aids because they are specialists. And I think the way that scanning is incentivized directly impact how the market operates. I was at it actually broke my heart. I went for a scan. So I'm in the privileged position to have access to these things, right? Because I have a healthcare business. I've got images on all my branches. My doctors are trained and so on to do it. So I was struggling with very bad right upper quadrant pain, nausea. It was horrible, and it was to the point where I was first I thought it's probably something small, and then it got worse. Then I was hoping it's cholecystitis, and then I kind of was hoping it's maybe a gallstone, because my brain was ticking over, and because I have access to it, I obviously was able to get an initial screening scan at a GP practice, which I own. So I went in, I paid, I paid cash for it. And one of my doctors was able to do a scan. I actually think I sent the scan to Joe. I said, Joe, look at this hyper, thick rimmed wall, blah, blah, blah. And, but that turned out not to be the problem. So I end up getting this bedside scan done. And in the process, my doctor decides, actually, I think you should go for a formal. So it was inconclusive, or it wasn't clear enough. We were hoping to see a gallstone or maybe a very clear cholecystitis, which we couldn't see. So I go for the formal scan. And ironically, our bedside scan image was a lot better than that one. But it was at a formal radiology department, and my medical aid didn't cover it because I'm on a hospital plan. So I had to pay out of pocket. So while I'm standing at this department, I'm thinking to myself, and I'm speaking to the lady, and she's saying to me, and I actually mentioned what we are doing. Like I mentioned this to her. And I said to her, I'm in a privileged position where I can actually afford to pay for this. I literally looked to the right, and I saw a young mom with a kid. And I just knew, like, you can just, and it's not, I'm not judging. It's just, I'm making an assumption based on very superficial things, but I'm looking at it and I'm like, this girl, there's no way this girl's able to actually comfortably afford to pay for the scan, and it's going to cost her like 4 grand for a basic ultrasound scan, right? And this girl's son was there, and I know for a fact after speaking to the lady at the reception, that she didn't need that scan, actually. If someone had done that bedside scan at her GP, because the GP referred her there. So she didn't have medical aid, but she had to fork out the money for that very basic ultrasound with a basic abdo. I think the boy had constipation or something, if I can't remember now, but something simple. But for me, I happened to have my scan. I got my formal scan, was inconclusive. And I ended up getting a CT, and we found a significant sort of diaphragmatic hernia, and it was causing pressure on my phrenic nerve. So I had phrenic nerve root disorder. Who would have come to the diagnosis of phrenic nerve root disorder?
Right.
You know, like that. And so the point I'm just trying to make is there's a patient disposition or a patient pathway where we as clinicians and focused orientated doctors can actually influence that patient's disposition in a big way. If that mom really had a basic abdo done at a GP, maybe it cost him 500 Rand or 650, it would have saved them a lot of issues and money and time and so on.
Yes.
Because all they saw was constipation. They just saw some poop.
Yes.
You know, so
Yeah.
so it's really, you know, there's a unique opportunity within the space. If all of us should start thinking about where we can apply focus, we are going to be doing a lot of education, even on the GPs who have the practices, because they don't know
Yes.
when and where they can or can't do focus. And it's not their fault. It's just not been part of curriculums. It's not been part of how things are done. So this is it's going to be a case of when you go engage your GPs and so on, you actually going to be teaching them and saying, did you know you could potentially do a focus here? You could do it here, etc. So I think, yeah, it's very important to differentiate the public and private. And then I think as we go through the clinical training, you guys will quickly start seeing, but hey, man, I can actually improve patient disposition by understanding what I can and can't do focus for. And you won't know everything. It's impossible. But just understand.
Definitely not.
Yeah, it's just understand that there's a burden on the patient, on the customer. In this case, the customer is the patient. And the burden sits with them because medical aids are not always paying it. They don't even know what they're covered for, etc. So, yeah, and you will get pushback from radiology also. But then the flip side is that you're actually you're screening and you end up increasing the number of formal scans that get done, actually.
No, and Chet, in reply to something that you just said with your personal case, I can definitely, before I start into this, relay something to you guys. My wife went for an MRI for something routine that she's had for years. And in that MRI, everything else was normal. And the MRI doctor, radiologist, looked at her when he was reading this thing out and said, oh, by the way, you have a mass in your liver. Now, you know that when you tell a non-medical patient, even a medical patient, that they have a mass in their liver, the first thing they're going to do is panic, right? And so, you know, she comes home and she's like, well, the doctor said that I have this, and she shows me the report, and I'm saying, oh, wait a minute, you got a mass in the liver, and this is not good. And he wants her to go for a biopsy because that's the first thing they're thinking is, this is, you know, this shouldn't be there. It could be malignant. Let's get a biopsy on this thing. And I said, you know, she's freaking out and I'm freaking out because she's freaking out. And so I said, you know what, sit down for a second. So I run upstairs, get my handy little U-image ultrasound machine. And I said, lay down. I scanned her liver. She had a 9mm hemangioma in the left lobe of her liver. I went and I pulled the MRI and I compared them, and it was the same mass that he was looking at. You see what I'm saying? The go-to is not to send it to a GP or whatever. The go-to is just to bypass ultrasound because nobody has the knowledge to say, hey, let's just look at the liver and see what's going on. And I asked him, I said, why didn't you send her to ultrasound? He said, well, ultrasound was busy that day. And I'm like, that's not an excuse. That's not an excuse.
And the
so
MRI is so expensive and such a difficult resource. I mean, it's a privilege just to get access to ultrasound. To MRI.
Absolutely.
That in itself is a. And I just want to add one more anecdotal story quickly before we go on. So my daughter, so my wife, we were pregnant in 2020,
Wait, Chad, you were pregnant also, or was it just your wife that was pregnant?
We carry, it's like it's us as the men, we also go through it. So obviously, again, because of the way the industry is structured, it's not necessary that you go to the gynae for your sort of pregnancy, right? That just is the way it is in our private sector, because that's just how things are. But in reality, it could be done at a GP level, initial scans, and so forth and so on. Anyway, so my wife, so I've got a very big head, like physically, not the other one, but physically, and basically I was convinced she has CPD. Like there was just no ways that. I mean, I couldn't see it happening. My wife's petite, and we're going through this process, and the head's just not descending, and we're getting towards 38 weeks now, and I'm worried now. I'm like, Jesus, this baby's just not coming. And the one evening, again, just because I had access to it, it's uncommon to have access to it. I just took out my image, and I said, let me just have a look. And we saw, calcifications on the placenta already. Everything else was fine, but this head was just way up. And I just said to my wife, just phone our gynae and say we want to do a consult tomorrow. And it was the next day we went in. She assessed it too and said, okay, this baby's not coming out. We were going to do NBD, and in that moment, just because there was this intermittent there was the introduction of POCUS in between, she was comfortable. She agreed with what we saw, and we booked the C-section for the next day, and the baby came out. So it became an emergency elective, if that makes sense. But it would have been most likely an emergency. It would have been, we would have done NVD, and we would have seen the CPD, and we would have ended up with an emergency. All that trauma,
Yes.
all that, etc., etc. So, I think there's just an element of improved outcome when you find gaps for POCUS. We had a similar thing. Again, this is a personal story, but where we had a very good friend of mine whose wife had unexpectedly fallen pregnant. And again, having access, etc., she just asked my wife just to scan her one evening. We actually went to our house. I mean, where do you do scans? In people's living rooms? We popped one of my doctors popped the device on, and unfortunately we couldn't see a fetal heart, and unfortunately it was a miscarriage. But ultimately we picked it up early before she developed any real complications. She didn't develop any sepsis. We actually were able to alert her to it early. It was sad, but obviously for her, she was like, geez, she would have probably carried on for another 2-3 weeks, unbeknownst to her that she had and she might have ended up, in hospital and so on. So these are just not MSK obviously related, but it's just, these were real world things, and there were hundreds of these stories over the years where POCUS kind of filled that gap and improved how quickly care was delivered.
100%. Thank you for that, Chad. Can you see my screen?
Yes, I can. Yeah.
Okay, cool.
I saw it on Sia's WhatsApp status. So that's how I know it's there.
Oh, okay.
Yeah.
All right. So just to start off with, guys, so what we're doing with you professionals, with you healthcare professionals, you doctors, is we're actually enhancing care at the primary care level. Basically, by teaching you how to do this and by getting you credentialed eventually, we want to enhance care. And my whole company's mission is to empower healthcare in Africa through POCUS training. And I ultimately strongly believe that can happen. So basically, when I'm talking about POCUS training, and it started out, of course, we know, with obstetrics. Everybody was, because of the WHO demand to reduce maternal mortality in some parts of Africa, and worldwide, everyone wanted to do POCUS in obstetric care, and that's where it started. But as we know, it has expanded past that. So how exactly, what's the training model look like right now in Africa? And I want to give you an overall view of the ecosystem when it comes to training, so you know where you fit in with the rest of this continent. And I include the Caribbean into that continent. So basically, the introduction says we're setting the stage by introducing the significance of POCUS training in improved maternal and neonatal care. And I'm going to add to that maternal neonatal care and general practice. And by general practice, I mean vascular intervention, I mean cardiology, I mean HIV, MSK, trauma medicine, and just general abdominal scanning, as well as soft tissue and biopsy. Providing. But see, when we started this was just pointed at obstetrics. The training methodology was very, very simple. You have to understand the specific methods and approaches used in training healthcare professionals, because that's what you're doing. You're training post professionals. What I mean by post professionals, these professionals have already graduated school, whether they're nurses, doctors, medical officers, other medical practitioners. In the US, we have now the what we call the PA, the physician's assistants that are now practicing POCUS. Midwife has practiced it for years in the US and Australia and Europe, and now we have it branching out into other fields. So we have to understand how it is that we train healthcare professionals on POCUS, because it's different training you after you're out of school versus training you while you're still in school. And then what are the phases of training? We have to explore the different phases involved in the comprehensive POCUS training and program for healthcare providers. How do you go about training adults? You do it in phases. And is there a timeline? Definitely there's a timeline. We have to highlight the crucial role of the well-structured timeline in successfully implementing POCUS training. So if you look at all that, you now begin to understand that it's not just a once-off haphazard thing. POCUS training is basically like what you went through in med school. It's very methodical, it's in phases, and it has a timeline. So basically, the way that we do it and the way that we're doing training now with you is we first do a sensitization webinar. We introduce the concept of POCUS by a webinar. We used to, actually, if you look at the way we used to do this 3-4 years ago, we used to just have massive hands-on training for POCUS. But then we realized that we were actually wasting time in doing 3-4 day trainings for POCUS, because part of that training was to orientate the people to the equipment and to also orientate them to the actual physics of ultrasound. There is a physics of ultrasound. Basically now we do that all online, because the physics of ultrasound does not have to be practiced in person. You need that to pass your boards. You need that to understand how the machine works, but you don't have to sit in the classroom and do that. So the sensitization webinar went through all that. We did a couple of things there. We basically became aware of the context and the setting of POCUS, right? We aligned the expectations of the people, the professionals like yourself. What should you expect to be trained in POCUS? I can tell you that what we're going to go through with my team, and my team puts together all the training materials for you. They basically want to make sure that what you expect is what you get. And if your expectations are a little misaligned, we change those. We already know that nobody here is going to be a sonographer. No one here is going to be a radiologist. No one is going to be an obstetrician. We're going to be professionals that know how to use POCUS in the atmosphere in which we find ourselves, whether it's trauma, MSK, vascular, obstetrics. We need to find out and figure out how to use it. Then we look at the engagement and the motivation. What is your motivation for learning how to do POCUS? If I were to ask all of you, you probably would have the same motivations, and there would be similar motivations. There'd be some overlap, but there'd also be some differences. And then how do you prepare? How do you prepare to learn how to do POCUS? And then how do you build into a community? POCUS is also a community. One of the things that we found out, and I don't know if it's the same thing here, and I probably suspect it will be, in Kenya, when we trained POCUS, we found that if we set up a community to support the people that we trained, the outcomes were much better. So we set up obstetricians that knew how to do POCUS and were willing to support the nurses that we were training. We set up radiologists that were willing to support the people that we were teaching to do vascular intervention and to do abdominal ultrasound. We set up community doctors that would now take these nurses that have been trained and look at their images and say, yeah, that may not be good or that may be better. And then we also set up a feedback mechanism. We set up WhatsApp groups. We set up an LMS system where the doctors, the nurses, the medical clinicians could go onto the system and ask intelligent questions and get intelligent feedback responses from. So you definitely need a community, and you definitely need to build a feedback mechanism into the training, which is what we're doing by having these webinars. And by engaging with Chad on the business side of that, that is actually a really good building community for this. A lot of people do not learn the business side of this at all. They only learn how to scan, and they learn how to tell something normal and not normal. They don't go about setting up a community. So, the effective training methods of POCUS. What do we mean by that? There's a way to train for ultrasound and a way not to. I've been to medical schools. I went to Johns Hopkins, and the head of the ultrasound program there, Johns Hopkins, is a very, very good instructor and a really good friend of mine in Washington, D.C. And one of the things he said in teaching the thousands of sonographers and radiologists that he's taught over the years, he said, if you don't treat POCUS like you're treating surgery, teach it right the first time, or else someone, and it's usually a patient, is going to have a mishap because you either made up something or you missed something. And I took that very, very seriously when he told me that. So there is a particular training methodology for POCUS. How do you train so that you enhance the knowledge that you're giving? Well, the first thing we do is we do a lot of virtual lectures, right? Which is what we're doing right now. We do virtual webinars, we do virtual lectures, and a lot of you, and trust me when I say this, a lot of the people that we train, and maybe some of you, will go on to become trainers yourself. You will go on to say, wait a minute, I know how to do this, I have experience doing this, my outcomes are good, let me teach 2 or 3 people how to do what I do. So this is going to be helpful for you. Virtual lectures, which contain weekly or bi-weekly sessions that are held over a specific training period to ensure that there's constant learning and that there's constant practice, because ultrasound is not like riding a bicycle. You don't not do it for 5 years and then pick up a transducer and all of a sudden still know what you're doing. And the format for these classes could be live presentations, live demonstrations, questions and answer sessions, breakout discussions, and it involves comprehensive learning and interaction. I find that when I'm in a room with a bunch of people with transducers, I learn much better, right, than when there's only one person lecturing at the top of the room. And this is when we get into the hands-on portion of it. So the training phases, the POCUS training, and when we did maternal, when we started in South Africa doing the maternal and neonatal, we found out that exploring the key stages of POCUS training was the beneficial things to the nurses and doctors that we were trying to teach. One of the best things that we did is we got really, really good expert sonographers that knew what they were doing. They also knew how to teach. One of the benefits of living in South Africa and actually living in Africa versus when I lived in the States is in the United States, sonographers were not allowed to have their own practice. However, in Africa, that is not a thing. Sonographers can have their own practices, which helped us when we were training because we could actually send the nurses and the doctors into the sonographer's practice to intern for the day, for the week, for the month to get extra knowledge. So the training phase was a lot of hands-on in one place. You tend to learn really quickly because you kind of pull from all the learning and all the knowledge around you. But to do these conferences, especially when we started out in East Africa, we had to get the timing right? We had to get the format right. And we had to make sure that the sonographers that were trained were readily evaluated. Now, I'm going to pause there. Any questions so far? We're just getting into the meat of this. Good. So you guys are still with me. Excellent. So one of the important things, and I mentioned that some of you may go on to learn how to train, is the TOT programs. We have to train trainers, and that's what my team, that's what Chad is doing. We're training you to become equipped not only to actually do the ultrasound, but you may find yourself in a teaching situation where the GP that has contracted you, you're actually teaching him or her, unbeknownst to you sometimes, how to do these kinds of things. So in Kenya, we had an objective to empower Kenyan sonographers. And that objective became very good because we saw that when we empowered the sonographers or the nurses or the doctors to train, the training went much better because it was culturally relevant at that point. The outcome, local POCUS expert and mentors were formed. And the trainers then served as the local expert, ensuring that the sustainability of the training program was at 100%. We found out that when we just did what we call parachute training, we jumped in, we trained, we left, it was not sustainable at all, right? So there was a special training curriculum that we went through just for trainers. And as when I train you guys and in person, we will hit a couple of these protocol, what I call bullet points. We'll develop a comprehensive training curriculum to enhance maternal, neonatal, vascular, abdominal care through Africa, because we just don't want to stop here. We want to actually, this should be the first section of your training, right? So as you learn and go out and you do your GP business, you should then come back to me in a month or two and say, Joe, hey, we learned how to do this, this, and this. I want to learn how to do HIV because a couple of the practitioners that I deal with are doing HIV patients. They're doing hepatomegaly. They're doing splenomegaly. I want to learn how to do cardiac. Basically, the projection in Africa from the OEMs, the original equipment manufacturers like Samsung, Mindray, GE, is that in the next 4 years, there are two fields that are going to explode in Africa when it comes to income producing. It's cancer care, oncology, and cardiology. Because we already see that a lot of these OEMs, a lot of these equipment manufacturers are actually putting massive R&D dollars into cardiology and into oncology because there's not enough oncologists and not enough cardiologists on this continent, okay? So Chad just asked a question. Please put it in the chat. What specialties are you looking at? What specialties are you especially interested in that you would want to say, you know what, I want to go a bit beyond just abdominal. I want to go a bit beyond just first trimester pregnancy. I want to learn how to do this. And it could be as wide as your imagination, because once we teach you how to use that probe and actually train you about what you're looking at, you could take that to the limit. You could actually go anywhere you wanted to go. I know people, I do know one sonographer in the United States that took this to the limit, and now they're doing advanced veterinary sonography. The veterinarian has hired this person and their team to actually go into zoos and ultrasound these animals as these animals are anesthetized for certain things. So your imagination is where you need to go with this.
I just want to comment there. So obviously so as Joe is speaking about, where the market's going and kind of readiness for that, there's a lot of downstream effects of the industry moving in a certain direction. So I think even things like Joe was mentioning, onco and oncology care, at the same time, not everything will be handled at a tertiary or super specialist level. A lot of it will then be syndicated into primary care. And if you think back to NHI, your basket of care is going to dictate what you can and can't charge for. So if you equip yourself with these skills, and ultrasound is going to become increasingly more prevalent. We say specialty, but it's obviously at a primary care level. It's going to become a lot more prevalent as the market evolves. And I wouldn't say less skilled, I would say less specialized clinicians are going to become more and more, or expected more and more to be utilizing ultrasound. So that's where the market is shifting. So we at OEM too, as you image, so we positioned ourselves from a, I guess, market point of view to focus on primary care. So doctors, nurses, etc., and bringing in the tools and stuff and the training to equip it. So there's another question in the chat about, are we going to have an opportunity to do like an internship of sorts for more practical input, or is it just the 3 days? So basically, yes, there'll be continued support for the next 12 to 18 months as we go through. And ultimately, you guys are obviously forming part of the entire community. So Joe and our clinical teams and so on, the LMS and the webinars and things will be available. And then we're going to be doing sort of check-in sessions once you guys go into the market. And you're going to learn and you're going to get feedback and you're going to struggle a bit and you're going to be good at certain things. The idea is that the LMS is like a community platform that any questions and things can be presented. The team of sonographers on Jodim's side will also be available and we'll be able to kind of we'll hopefully do more webinars like this, or we'll break it down into smaller groups. And then also there's an opportunity here while we built the LMS. I know we've had some small technical challenges with uploading things and so on, but trust me, it's worth it for what we wanted to do. But it's a longitudinal learning platform. So as we go, we'll introduce more certifications, more opportunities for you guys to get involved. And you guys could actually then long-term upskill yourselves more and more. So we'll make all of it available. There will be long-term now, like post this initial period, when you guys want to get into more specific things. We obviously have direct relationships with some of the international certification partners and ourselves as certification partners. So we'd be able to bring in certification at a much more cost-effective rate. That's the whole purpose of what we try to do. And you guys will then become part of that community going forward. Yeah. So yeah, I think that's just how I would kind of frame that. And then I think so again, if you think about, and the reason I also posed that question, Joe, about which specific things, is because if we look at the private sector at the primary care level, we also going to need to go and identify where we can fit in, where we can fit POCUS in, because the reality is that the private market, which is run like predominantly by GPs, traditional GPs who don't have POCUS experience or ultrasound experience, the opportunities to deliver POCUS are going to become more prevalent as you go. So now we think, we know appendicitis, we know gallstones, etc. That's all abdo-related stuff. MSK, very useful. You can do intra-articular injections, you can do aspirations. Very common lumps. I think in the business training, I showed you guys the one lumps and bumps one, where it was the thyroid. It was a thyroid system. I can't remember now. So there's a bunch of opportunity for POCUS to be put into play. But the exciting part and the challenge also from our side, other than selling the service or the concept of the service, is actually building these new pathways by identifying opportunities for POCUS to be put into play where it isn't maybe being done right now. Okay, so I had the privilege of presenting our business and POCUS and stuff at the National Pathway for, not National Pathway, the National Perinatal Morbidity and Mortality thing in Parliament, right? So it was a whole thing, and long story short, the idea was, how do we get this into the hands of more interns so that they can take it with them into internship, so that they could actually learn and go through it under supervision, and then come ComServe, they'd obviously be more equipped and they could do more with their device and their skills. And one of the biggest questions that came up like repeatedly was, what about the referral pathways? And by that, they meant,
Yes,
if you're doing more scans in the market now, what's the downstream effect of doing more scans? Who are they going to be referred to? How are you going to ensure that they get, and this was obviously not from a public sector point of view. This was their, I guess, they were challenging it because they were saying, where are they going to go? And it was a very easy thing to answer, because the purpose of internship and primary healthcare is to screen and appropriately refer. That's the job of a primary care doctor. So it's getting a history, making a diagnosis, and appropriate time is referral. And
yes,
they basically said, well, geez, if we could find a mechanism to fund this and we could have all the doctors trained and certified and they're operating under internship being, there's logbooks, there's all that stuff. Why not? Because ultimately you're going to improve patient disposition. So, yeah, I think I wanted to ask you because I wanted you guys to think a bit about where we only know you don't know what we don't know, number one.
Yeah.
And we also don't, I think, have enough foundational knowledge and experience across the board in focus to know where all the places are we could use it. So like, I think that's a unique thing to think about, that you're still going to identify opportunities for focus as you go.
Yes, yes. And I think that we haven't even scratched the surface yet, Chad, on where we could possibly interject a business model into different specialties. There was a question there that asked about internship, and amazingly enough, I had a discussion this morning with two sonographers that have really good practices in Joburg. And we were talking about focus training because I was trying to recruit one of them to actually be one of my trainers because she's really good. And she's gotten her training in the US and came back to Joburg to practice because her kids and her husband are South African. So she's living here now running a really nice practice. And I said to her, I said, so if you were to do this, and I know we're training, and I told her about the program, Chad. I told her this is what we're training. I said, could we then have doctors do like rotation with you? Just come in and spend, a week, 2 weeks, whatever the time limit is. And you could actually look at what they're doing, make sure what they're doing is right. And, check them off on certain things. We have standards that you check them off on. And she said to me, she goes, absolutely, that's a plus for my practice. And she goes, and plus, I know sonographers that have their own practice that would love to do this. So that's another opportunity. I mean, not all sonographers out there are opposed to doctors learning how to do ultrasound. A lot of them see the business benefit in that, Chad. What you're talking about is the referral pathway, right? Because if one of these doctors finds something and that ultrasound technologist has built a relationship with you, Mohammed, then you're more than likely going to refer it or ask your GP to refer it to her or refer it to him. So these sonographers now are seeing the business end of what could happen if they train more GPs to be able to do ultrasounds. You see what I'm saying? So it's limitless. And then to add to what Chad said, what specialty, where do you see, let's use your entrepreneurial mind for a second, right? Where do you see POCUS fitting in that it's not already fit into? Somebody came to me and asked me, and I didn't have the capacity, my group didn't have the capacity to do this. This was about a year ago. And they were talking about the cruise ships that come in and out of South Africa. They're cruise ships that come, and they're like, we could use ultrasound service in the medical wards of those cruise ships, because a lot of times these outpatients walk in and they have gallstones, they may have a lump and a bump, and it'd be nice to train the cruise ship technicians to be able to do ultrasound. That's another practice. That's another place that I didn't think about fitting in, So I think that there's, again, it's where your imagination can take you. Where can your entrepreneurial sense take you? Somebody said musculoskeleton. That's very, very good. Musculoskeleton is, I only have two technologists that I trust to teach MSK because it's such a highly specialized field. But once you learn it, it is unforgettable. Very, very common. Vascular intervention. Another one that was brought up to me the other day was renals, right? A lot of the renal clinics send their patients to radiology after they've done transplants to check for transplant rejection, vasculature in that transplant. But POCUS has an examination for renal POCUS. There is an exam that Intellius has for renal POCUS. What if you went to and sold your services to a renal clinic, to dialysis clinics? That's another thing that you could do.
That's a very common, well, not common, that's a very practical thing Joe mentions there, because there's two parts of it. They need imaging, and then at the same time, you guys know, or maybe don't know, but obviously the specialists that run them, they still need GPs to deliver some of the non-specialist services. So they still need GPs to collaborate with them on basic UNEs, outpatient stuff. You can 100% do the basic renal ultrasound for them at a sort of primary care level, and it's all about, I guess, it's distribution of the service, and the reason why a lot of it's not distributed is almost exclusively because there's not enough skilled people to do it. So, if you, and I think we spoke about it the other day, I think it was Muhammad, I think someone said it, but where they were saying, oh, but so we're doing the job of a sonographer. So I said, yes and no. Yes, you are fulfilling a role, which a sonographer, you're doing a thing that a sonographer can do, but that's the only thing that a sonographer can do. You are coming in as a doctor. This is why it's so different to train nurses versus doctors. With the nurses, there's very little anatomical foundation for them to work from. As the clinician, as a doctor, you've got an incredible an anatomy baseline, but also you've got a much deeper clinical insight. So it's a beautiful sort of combination of things to bring in both the clinical plus the, I guess, sonography level of it. And the sonographers themselves, I think to Muhammad's point there about them being employed, so that's the case. So before we did this, I think I interviewed about 100. I think there's only 100. I interviewed about just under 100 sonographers from Cape Town and Joburg and so on. And I was just trying to ascertain how they operate. And it's like you say, Mohammed, most of them end up working either in state, or they work for a radiology hospital, or radiology group, or directly for the hospital. Remember, in the private sector, most hospital groups, like a Mediclinic or Intercare, they are ultimately expensive hotels. So the infrastructure provider, which is then the Mediclinic or the Intercare, they send separate bills to the patients or to the medical aides. The doctors or the clinician bills separately, he or she himself. They need to pay rent to the hospital group. And the hospital group generally covers mainly the nursing staff and so on. That's their overhead. So yeah, exactly, Mohammed. They're getting net commissions per scan, and that's the model, right? You guys can go, well, this was the gap we saw, and it's a case of how you position the offering holistically within your business, with the skills that we're going to be equipping. Yes, we obviously can't train everything immediately right now. It's going to be in phases, but the idea is that we equip you guys with a good foundation. Then there's continued access as your business develops, as it grows. You decide you want to do another thing or specific thing. If enough of you guys get together, we'll say, cool, we can do a training on that. You guys have the best on the continent at your disposal to do it. There is no one better. And I'm not saying me, I'm talking about like Joe and the team. We just obviously identified them as being the best, and we've come a long way. And we're hopeful that as we go through this journey, when you guys get the gist of it, and you start engaging with the market, and you're going to get pushback, you're going to get pressure, this can't work, and that's fine. But the reality is the market is moving in that direction, and you guys are going to be a step ahead of everybody else.
No, it's interesting, Chad. Muhammad was saying that he's come across hospital groups that are employing sonographers. I recently consulted with a builder, and he was not a medical person. He was a builder. He built container units for hospitals. Remember during COVID when we all had to fly and we all had to go into Four Ways Life or Netcare, and in their parking lot they had these containers, and we'd go in and get the things rammed up our nose to test. Well, he builds the bigger ones that actually look like buildings. And his new building model now in East Africa is he's now putting these containers in the parking lots of hospitals. I said, well, what's the advantage there? I said, who's the client? He said, the radiology departments are hiring sonographers and putting them in those containers to do ultrasounds that they don't want to do in the hospital because the hospitals are too busy. So I looked into this, and it's not sonographers that they're hiring. It's actually medical officers that are being trained to do very, very basic ultrasounds that the radiology department don't want to be bothered with. So we happen to be blessed to live in a country where that's not regulated. It's not so tightly regulated like in the US, right? So I think that there's a huge business opportunity. If I were to tell you there's a business opportunity, I would be underestimating. There is a huge business opportunity. And remember that if you look at the ARDMS website, I think there are now 12 different specialities of ultrasound, right? Everything from even ophthalmic ultrasound that people are doing now that the ARDMS can certify you for. So again, the imagination is where you need to take this. Now, moving forward,
you don't need to be an ophthal specialist to do ophthal specialized ultrasound, right? So that's the beauty of it. To Joe's point, you are effectively equipping yourself with. We're going to be going through this journey of equipping with a skill that was previously just for specialists, but now you are a GP with specialist skill in specialized specialities. So like, I know a doctor, I'll try to maybe get him on one of the webinars. Some of you might know him, but he's a local doctor, and he does, when I tell you, he works for the state though, so he's a government doctor, so you can't really build a business around it, but it's remarkable, guys. He's shifted. So I've always seen focus as an extension of your stethoscope. It's like stethoscope 2.0. Instead of hearing the thing, you can see the thing. Right? So with the stethoscope, playing guessing games, like the art of medicine and all that stuff that they want us to believe, and which to a degree there is an element of it, yes, but obviously that's the construct is archaic. So now this doctor, I mean, he's replaced his stethoscope in many settings and now only uses his image as a tool. So he does everything he even does ophthal scans. I'm just like, what? Like, it's mind blowing for me what he does. Like, I mean, it's amazing. And he's a family physician, yes. He has a sort of specialist background, but he's adopted focus into his public sector services as a means to improve patient disposition. So you will always, every now and then, you'll send me like a picture or something of, maybe there was a breast mass or something that he scanned, and they said, Chad, look, I sent it away for formal scanning, and then they ended up doing maybe something else, maybe they did histopathology on it or whatever, and then he's like, this is what I thought it was an ultrasound, and then he sees what it was, and it was right. So just having this skill and a broad skill of being able to identify, not necessarily knowing everything, but just knowing what you are seeing based on fundamental principles of ultrasound. He was able to adopt the skills himself, specialization. If that, I don't know if I'm making sense there, but it's basically what I'm saying is like that foundational skill set you have and understanding. Once you're comfortable identifying certain structures and pathologies and things, the body it looks the same almost everywhere. Like it actually looks very much the same. It's just obviously in different sort of parts of the body and different specific criterion to get to a diagnosis. But what you're seeing is fundamentally consistent across, the body, different structures.
And that's when you know, because if it's consistent across the body, what you do is you look for the inconsistencies. When you see something that's not consistent, that's when you know that there is a pathology presenting itself. You may not know what the pathology is, but there's a pathology there, right? And so when you look at the training for non-imaging physicians, which is the phase that we have you in, because you guys are not usually, you don't fall into the radiology, into the sonologist or the sonographer pathway. You're non-imaging physicians. So there's just a couple of objectives that we look at there. Number one objective, we need to introduce the non-imaging physicians to POCUS. All over the world, India, it's happening huge. I came back from Pakistan about 5 years ago. POCUS was a thing in Pakistan 5 years ago. in the Caribbean, my home country, right, of the Caribbean, cardiac focus is now taking off because there is not enough cardiologists to do, or cardiac ultrasound technologists, and they have thousands of people waiting for echo. So we need to, you guys are the first line of introducing the non-imaging physician to POCUS, because we're going to provide training on the point of care ultrasound. Non-imaging physicians can then enhance their diagnostic capabilities in ultrasound care, leading to improved patient outcomes, because that's what we want, is improved patient outcomes, right? Number two, we need to equip the non-imaging physicians with the necessary skill for use in every single kind of patient care cadre we can think of. Obstetric is highlighted here, but again, we're going after every specialty that you can imagine, because by empowering these physicians with those skills, we utilize POCUS, and it enables a timely and accurate diagnosis. In medicine, time is life. There's a story that somebody just broadcasted. I belong to a couple of the WhatsApp groups all over the world for POCUS, and the one that I belong to for Nigeria said that thanks to now they're teaching the ambulance technicians, the emergency techs in the back of the ambulance to do POCUS. A lady presented, she was a middle-aged lady presenting with chest pains. They thought she was having a heart attack. They took her to the hospital. On the way to the hospital, the gentleman in the back was just an EMT, emergency medical tech. He had a POCUS unit, handheld unit. He started scanning this lady just as an EFAST and looking at her heart. Was there a tamponade? Was there pericardial effusion? Couldn't find anything. And then looked at her midline and saw her aorta and found and couldn't understand what he was seeing. So he called ahead to the radiologist of the hospital where he was going, because he knew the doctor, and he said, look, I'm sending you this picture by WhatsApp. I don't understand this. I think there's an artifact here, because I learned when I was doing POCUS that an aorta should only have 2 lines, and this one has 3. Well, you know what was happening? The aorta was dissecting out, and what he was seeing was that that tunica meter that was coming apart. Now, the lady was rushed right into the theater, did not bypass radiology, did not bypass accident emergency, and effectively saved her life. So this is what I'm saying. The specialties that we're thinking about could be widely varied, but time is life. And if I can teach someone to use a POCUS instrument and tell me, is that baby have a cord around his neck? Is there a cord knot? Is there an appendicitis that is about to rupture? Is there a hepatomegaly in a HIV patient that's on meds? That becomes increasing the output of these patients, right? And then number 4, we need to introduce non-imaging physicians, because by introducing you guys to POCUS, we're providing training, right? And it's going to enhance all your diagnostic capabilities. Basically, is what Chad was saying. Once you have that ultrasound in your hand, how are you going to use it? How are you definitely going to use that ultrasound machine? Because the list is long of things you can do. And what you're going to find out is what we teach you, you're going to go far beyond that. So just this one point before I go ahead. Yes.
Can I make one comment there? So I see it's quite a common thing about the medical aid and so on. So we will get into it, but you guys can go check for yourselves also if you're bored. But there is a specific ICD code. Let me just check quickly. See if I can remember. There's a specific procedure code for just sort of ultrasound, right? And that one is what you can always use for medical aid when you do the billings and stuff. So when your GPs that you working with, they'll be able to then charge ultrasound, right? And so that's sort of a general rule, but you can obviously also charge cash and so on. So I was just going to make a comment about the POCUS to ER24. So a year and a half ago, I was in a meeting with the state version of it. The procedure code is 3615, just by the way, for ultrasound. I just checked quickly on the ICD billing stuff. 3615. So there is a medical aid billing code, procedure code for ultrasound. How much does it cost? How much can you charge? Let me just see. It's not a medical aid version, but I just wanted to see. Okay, so We charge between 450 and 650, but this is now in a GP setting. But each medical aid has different rates for this basic ultrasound code, which you can always use. But for an ER24, so when we work with the state, we did a program with them about a year and a half ago in the Western Cape, where we put a device. So each ambulance only had like one registered person who could do ultrasound, right? So yeah, routine obstetric, and then there's another one for routine. There's another one for just a generic ultrasound code. I just can't remember it now. Yeah, anywhere between 450 and 700 is kind of the range. But and that's good because obviously when your GP that's doing this, that's whose patient it is, he's going to obviously push for the high end. And then you just you're going to make the bulk of that, and you keep a kickback for your GP. But on the ER24 thing, so the biggest thing that they had discussed or looked at was patient disposition, which is obviously how much time you can take out from the patient getting from where they are to the appropriate level of care. So what we saw was in the setting of an ambulance without ultrasound. Let's say there's an MVA, you on-site, roadside, no ultrasound. The process that you need to follow is stabilize, get fluids and everything stabilized. Then that patient needs to be taken to an emergency department, be it a front room or something. Then when they're there, they then restabilize, they managed again. So that's another hour. Then they get there. Once they're there, now it's a case of assessment by the triage, by the team. Once they've assessed, they find all the issues, then they say, okay, now refer to, I don't know, maybe they find something on a fast, a e-fast, or something along those lines. Now it's potentially a surgical issue. Now there's an auto issue maybe, or something like that. Then the patient maybe gets booked in. So that's 3-4 hours of delay. So what we saw with this, obviously this is now in state, so there was no real incentive other than getting the patient there faster. But when there was a POCUS device on the ambulance and there was someone skilled to do it, when they picked up free fluid, for example, or something along that, it resulted in a direct referral to the appropriate specialization. So it resulted in a direct referral to trauma surgery or a direct referral to wherever. You understand? So that's the opportunity, even because again, to Joe's point, the clinician that's equipped with this is able to go offer more value in even that ambulance setting, if you like, emergency medicine, because you could become a contractor to ER24 and you could be on a few of the ambulances, on rotation, if that's if you want to do that. And that patient will get billed. The medical aid will get billed for that scan that was done, either roadside or pre-hospital, etc. So there's really a nice mixture of opportunity that you can go. That's quite crazy, like cool stuff like that. And then the other side is obviously the day-to-day primary care. And I'm glad you guys went to go look at what these things are charged, what these things can be charged for, and so forth, because ultimately we're gonna end up influencing the market in a positive way. And if there's enough uptake from our side and us as the first group doing this more often, with the data we bring, we'll be able to then have make a challenge or a case at a medical aid level to say, can we introduce specific speciality scans and show it for them, right? And that's this is the sort of process you need to follow in changing how things are being done.
Wow, nice. Big changes coming up, huh? Big changes coming up. So what I wanted to do, and here's the boring part. I used to think this was the boring part when I was teaching technology. It's how to do ultrasounds and also teaching obstetricians, is that we need to learn the basic components of ultrasound. The next lecture that we have, the next didactic we'll have, will actually now start going into basic abdominal anatomy. But to understand the anatomy, we need to first understand the physics of how ultrasound works. What is the technology behind ultrasound? And for those of you like Mohammed who already have done some ultrasound, this may be something that you already know, but please bear with me as I go through it again. So we need to figure out and learn the core concepts of ultrasound, including how does it work? What is the physics of ultrasound? Why does it work? Because if we know why it works and you're getting a really, really bad image, you'll know how to fix that image. It's, the same thing as, you're driving Joburg Street. You can tell the people who know how to drive and the people who don't, right? Because the people who don't know how to drive are not taking advantage of the full capabilities of their car. One of the things that I always marvel, I always joke around with my wife about this. We're driving, and you can always tell the people that even bought their driver's license or they had the car bought for them because they're on the phone and they're actually, they're driving a Porsche Cayenne or one of these expensive SUVs and they're holding their mobile phone and talking to the phone. And I'm like, that makes absolutely no sense. You have no idea that your car actually has hands-free and you can do this. And I find a lot of ultrasound practitioners that haven't properly learned ultrasound, they're using their machine at 10% of its capability when they could be using it at 80 or 90 and getting a much better diagnosis, much quicker, and a much clearer image. So we need to understand how to use the equipment that we have. We need to understand how and why sound is produced, because ultrasound is basically ultrasound. I used to tell people that if you want to know medical terminology, just learn the meaning of the words. Ultrasound, above hearing. We need to learn why ultrasound interacts with tissue to give us an image. And we need to learn the key terminologies that are necessary for grasping ultrasound's medical applications, because this is what we're doing, is we're doing medical ultrasound. So basically, what is the definition of ultrasound? And when Shadrach, my trainer, put this together, I actually looked at it and I said, no, you got to take this down a notch because you're trying to teach radiologists. You can't do that. We need to take it down so we, as general practitioners, can understand why ultrasound acts like it does. What is the technical overview of ultrasound? How do we explore the characteristics and the applications of ultrasound in medical images and diagnostics? So what's the definition of ultrasound? Well, first of all, ultrasound refers to something that is above human hearing. Above, anything above, and we're measuring ultrasound in kilohertz, right? And anything above 20 kilohertz or 20,000 megahertz, 20 kilohertz is above human hearing. Now, we should not be able to hear above 20 kilohertz. In fact, if you're telling me that you're able to hear above 20 kilohertz, you're not human. It doesn't work that way, right? Because our eardrum does not vibrate. Now, a cat can hear way above that. It's said that a cat can hear a mouse's toenails walking across the floor, and that's at about 100,000 kilohertz. So it tells you that on the scale of Nat Geo, we're pretty low. So 20,000 kilohertz is about all we can hear. That is the definition of ultrasound. So when you go to take your ultrasound boards and they ask you, and listen carefully when I say that, because I actually help write the point of care fundamental ultrasound board, right? So when you go and take that board and it says, what is the definition of ultrasound? And it gives you all these choices, you're going to pick the one that says greater than 20 kilohertz, okay? Greater than 20 kilohertz. Please, there's not a lot of things I tell you to write down. That's one of them, okay? So ultrasound refers to a wave that is greater than 20,000 kilohertz. It's a mechanical longitudinal pressure wave. What do I mean by that? It actually can move things, right? And what we're moving is particles. Those particles are vibrating, and in that vibration is where we get our sound, is where we get our hearing. It's where we get, when the car pulls up to us that's blasting the music, it's vibrating these particles, and that is what our eardrums, our tympanic membranes are picking up. Above, for basic, it's above 20 kilohertz. Okay, so the frequency range. Medical ultrasound operates at different frequencies. We call that like frequency range. We call it broadband. We call it dynamic range. It has a lot of different words, but the frequency rates that ultrasound operates is anywhere from 2 megahertz to 16 megahertz. Okay, Remember, let's go backwards a little bit. Anything above 20 kilohertz is ultrasound, but the diagnostic tool that we're going to use, that the U-Image uses and most ultrasound diagnostic machines on the planet use, is anywhere from 2 megahertz to 16 megahertz. And the higher you go, the more detailed imaging you can do. So if let's say that I wanted to do imaging and I wanted to see MSKs and I want to see all those little striations of muscles and tendons and ligaments, I would use someplace in the range of 12 to 16 megahertz. Now, the problem with that is the higher the megahertz I go, the less penetration I get. And so physics says, the very law of physics says that anytime I get something, I have to give up something to get it. So when I get detail, I have to give up penetration. When I get penetration, I give up detail. So if I have someone weighing in at a lot of, I'm doing US pounds here, so forgive me. I had once a patient weighing about 500 pounds. We had to weigh her on the scales in the loading dock because she was a recluse and she'd eaten herself into just a frenzy and she had a lot of psychological problems. So do you think I could use a 16 megahertz to see her gallbladder? Absolutely not. You would not be able to penetrate the adipose layer of her skin. So in that case, I had to use a 1.5 or 2 megahertz probe just to be able to penetrate. But I gave up resolution. Remember, another thing I'm going to ask you to write down. Anytime you gain depth, you're going to give up resolution. Anytime you gain resolution, you're going to give up depth. You cannot have both. Can't have your cake and eat it too in this case. Okay? 226 kilograms. Thank you, Karina. Thank you. So ultrasound also moves longitudinally. If you look at the way the wave moves, it moves in a longitudinal manner, kind of like an ocean wave. And that's how I first learned the concept of ultrasound, is by actually understanding how oceans work, how that wave works. It travels through mediums by compressing and widening the molecules as it travels, enabling its imaging capabilities. And I'll explain that a little later. So as we said, the upper limit of human hearing is 20 kilohertz, which defines the threshold below which sound is perceptible, thus classifying ultrasound as inaudible to humans. Sometimes you'll hear your probe making a high-pitched noise. That is not ultrasound. That is just the mechanics in your probe, okay? Just the mechanics in your probe. Chad, you're killing me here. That's your max ever bench press. That's why you got your hernia, my man. That's why you got your hernia.
I'm not, actually, it really is. When I was powerlifting, when I was doing powerlifting, that was my max bench press. Sorry, I just random trivia.
Well, but you guys know that the US is the land of overweight, hyperstanding people, right? That's what you have. Basically, that's what you have. So the medical applications for ultrasound, we can use them in diagnostics, non-invasive imaging techniques, and there's also industrial uses for ultrasound. Every plane that you've probably flown on, the wings, the struts have been ultrasound by a special machine to make sure that thing is not going to come apart in the middle of the air. Okay, so that would be not medical ultrasound, that would be industrial ultrasound. So let's move on a little bit. We won't hold you here all night. The definition of sound wave. Sound is what? It's a mechanical, take a picture of this slide and you'll have this slide on your LMS. It is a mechanical longitudinal wave and we measure sound in hertz. Megahertz, kilohertz, millihertz, we measure it in hertz. The characteristics of ultrasound is it's characterized by oscillations per second. In other words, it repeats itself per second. If you want to look at an ultrasound, and those of you who have looked at an oscilloscope, you looked at cardiac waves, it repeats itself every particular sector of time. And for ultrasound, we're going to use seconds. We're going to say that an ultrasound wave repeats itself every second. Now, remember, you don't have to really, really know ultrasound to know these things, right? You just have to know real common English. Frequency, when it comes to ultrasound, is how many times that wave repeats itself per second. Frequency, when it comes to ultrasound, is how many times that wave repeats itself per second, right? The range of audible ultrasound, we said, was from 20 hertz to 20,000 hertz, and it covers a wide spectrum. And the measurements, the medium required for ultrasound is that ultrasound requires something to travel through. It cannot travel through a vacuum, which is why in space you can hear no sound, because there's nothing for the molecules to bounce around. There's no molecules there, it's a vacuum. So once you have something occupying space, then sound becomes audible. If I rap on my computer right now, that computer is solid, and what's happening is that solid is taking that sound and transmitting it, and my ears are interpreting as vibrations. Now, sound and when it travels medium, you have two things that make it travel. One is the density of the medium, and two is the stiffness of the medium. Those two things influence how fast the sound travels through that medium. So let's look at this, density and stiffness. Density is how tightly I have those molecules packed together, right? So we know that gas is not dense at all. So the molecules in gas are all over the place. They're not packed together. The other one is stiffness. Stiffness basically is how are those molecules lined up. The stiffer the material, the better the sound transmit, because as my molecules bounce, they don't have to go anywhere to bounce on each other. It's lined up. Whereas gas, when you have gas, sound doesn't travel very well through gas because the molecules are heather there. They're all over the place. They're not lined up, they're not dense, and so gas has a very hard time transmitting sound. How is that practical for you? That means that if that patient has not fasted and that patient has just drank a Coca-Cola and has come to your office for, let's say, a gallbladder scan, you may see nothing, because the gas in their belly is going to take that sound and ricochet it everywhere because the molecules are moving all over the place. That's why we tell our patients that, favorably, they should be NPO for a few hours before we do a gallbladder or an abdominal ultrasound. Not just so much that the gallbladder doesn't contract, but that we don't have gas interfering with this. So what do I need you to remember? Number one, frequency. What is frequency? Frequency is how the sound travels, oscillates, it repeats itself every second. Remember, sound travels in waves. So that wave is going to crash and repeat and crash and repeat every second. So it could be in 10 seconds, it could be in 1 second. But the frequency is the repetition of the waves every second. That's what I need you to remember about this. So let's talk about a little bit about the actual production of an ultrasound wave, because an ultrasound wave just doesn't happen. It has to be produced. Sound just doesn't happen. It has to be produced, right? So an ultrasound wave is produced in a couple of different steps. And because you have a U-image, or you will have a U-image transducer, you will need to learn how this is produced. Number one, you need a couple of things for sound to be produced. You need something to stimulate something, right? To have a reaction, just like in chemical reaction, you need a stimulant. In this case, the stimulant is electrics. It's electricity, right? It's an electric current. So what you're going to do is you're going to take electric current and apply it to something to stimulate something, right? And light behaves the same way. Something is stimulated by an electric current to produce light in that light bulb that's hanging over your desk right now. So in ultrasound, though, an electrical current is going to initiate the whole process of this. Number two, you're going to have some kind of material. Now, in the old-fashioned ultrasound, we used to have these really old-fashioned single crystals. Now, the machines we use sometimes have a lot of crystals associated with them. And the crystals are made up of a piezoelectric material. All piezoelectric means it's a fancy word to say that it can be stimulated. It's a crystal that can be stimulated and changed by electricity. So as I zap it with electricity, it expands and then it goes back, which creates the sound wave. So a material and I need you to remember this.
Josh, wanted to add there, so the handheld devices like U-image and so on, they actually run on chips, so it's chip-based. That's one of the big shifts in the last few years, was to shift from the piezoelectric crystals, which was obviously always very, very difficult when you remember how it used to be, you had to like guard it with your life, because if they broke, it was like, like no one was ever gonna be able to repair it. And that is because those piezoelectric crystals were and are still where they're being used in the bigger machines. They were very difficult to repair. So U-Image and the handheld ones, they use a chip-based technology. Yeah.
Which is interesting that you say that, Chad, because on the registries and certification, they haven't updated those yet. They have not updated those yet. So these kind of piezoelectric materials are still...
The technology that advanced beyond that now, yeah.
Yeah. So as Chad said, those crystals are very expensive and they're extremely fragile. If you dropped a probe back in the day when I was learning, that probe was no more good. It could not be used anymore. And when you turned it on, you'd get a blackout, basically a black mark across your screen to where the crystal had exploded or been shifted or cracked. So what happened is the electricity, right, zaps the crystal, makes it expand and contract, and then it generates a sound wave through all that. And that sound wave then is pushed through the medium, depending on what medium that you're using, whether it's, blood, bone, liquid, somehow it's pushed through that medium in a longitudinal wave. And that's how we get the applications of different ultrasound applications that we apply this to. So a quick overview, right? Transducer, inside that transducer, as Chad said, are different materials. I'm going to go back to the old-fashioned way because that's what's going to be on your, if you guys decide to get registered, it's going to be on your test. The transducer then generates an ultrasound pulse because it's zapped with electricity. The transducer is very crucial. And I mean, even though Chad is saying that, the transducers we use now are lighter, they're more electronic, still take care of them. Because usually if you really, really injure a transducer, beyond the point of bringing it back, it's completely useless at that point, right? So electrical energy is converted into mechanical ultrasound waves, right? But interestingly enough to know, in the old days, I don't know if this has changed, you only operated that transducer at 1% of the time during scanning. So what did that mean? That means that 99% of the times, that transducer was waiting for the signal to come back to interpret it, and only 1% of the time was it actually sending out the ultrasound pulse, right? So that's another interesting thing to know, is that your transducer spends more time listening than it does speaking, okay? Only 1% of the time does it actually send an ultrasound wave out. So the electronics in that thing is mostly dedicated to actually interpreting and listening to the sound as it comes back. So the echoes that are reflected back to the transducer are the ones that we shape, right? Rarely do we get to shape in any way, shape, or form, unless we're talking about power, the echo that's leaving. It's the one that's coming back that we can actually choose how we see it, what brightness it is, what wavelength is coming back at us, if we're using dynamic wavelength or not. It's the reflected echo that returned to the scan head that we shape. And we actually provide vital information by learning how to manipulate those echoes as they come back. So the conversion of waves to electrical signal is how we read it. So again, electrical signal excites the transducer, transducer sends out a wave runs into something, bounces back to the transducer and tells it that there's something in my way, and here's a picture of the thing that I just bounced on. That, in a nutshell, is what you're reading when you're looking at the ultrasound image. The key role of the ultrasound wave, the key role of the wave is essential in capturing the accurate images, which means that if you don't know how to manipulate that wave as it comes back, you're not going to be able to visualize in those internal structures adequately. And ultrasound is one of these sciences, as I said before, that you can either create a disease or make it disappear based on the settings of your equipment. Any questions so far, please put them in the chat or please stop me and ask, okay? So as we go on, what do we need to know about frequency and resolution? Remember we said at the beginning of this that the higher the frequency you use, the better the resolution you get. The higher frequency I use means that I can see things really, really well. The lower the frequency, I don't get as good resolution, but I get really, really good penetration. The way I used to explain this to students was the difference between frequency and wavelength. right? Because those two you're going to have to learn. And this helps you manipulate your image. The difference between frequency and wavelength. If you take a coat hanger, one of those wire coat hangers that you get back from the dry cleaners, and you unbend that coat hanger and turn it into a straight line, it could be like a meter long, right? You turn it into a straight line and you measure from end to end, and let's say that it's 1 meter. If you bend that coat hanger once and measure it from end to end, it is no longer 1 meter. It could be 0.5 meters. If you bend it 10 times and measure it from end to end, it's going to be even shorter. The more you bend that coat hanger, the shorter it's able to reach. That, in a sense, is frequency and wavelength. The frequency is the amount of bends that I put into that coat hanger, right? It's the amount of bends. That is the frequency. So if I have a transducer, let's use some common sense here, right? If I have a transducer that only has 1 bend, it's going to be able to reach a lot further than if I have a transducer that has 16 bends in it, right? So the 16 bends are the frequency. The higher the frequency, the more bends I put into it, the less the wavelength. The wavelength is the reach. So if I'm imaging someone, as Chad said, that's 226 kg, and I have a frequency selection, I don't even want to look at anything under 3 megahertz because I know that it's never going to penetrate that. However, if I'm imaging, let's say something like a breast or a thyroid or scrotum, testicles, something that's superficial, and if I try to use a 3 hertz, it'll blast right past the thing and I will never see it. Does everybody understand that concept? That is a very, very difficult concept for some people to grasp. High frequency, low frequency. If I have a high frequency, better resolution, high detail, but less penetration. If I have a low frequency, I have less resolution, not enough detail, but I can penetrate really, really a lot. Okay, so try to remember that. This is a very important slide for you to remember. When you get these slides, try to remember number 6, high frequency and low frequency. We need to understand how frequency affects the image quality and the penetration depth. So if I'm sitting there, and I've seen people do this, they're scanning and they're like, Joe, I can't get this picture. I don't know what's going on. And I look at their frequency and they're scanning, let's say, a first trimester pregnancy, but they have the frequency all the way down to 2 and they're getting no resolution. Well, she's a first trimester pregnancy. If she looks anything like most first trimester pregnancy, there's nothing to her uteruses yet. You don't need all that penetration. Bring your frequency up, and so that you sacrifice your penetration for resolution. Okay, so that's very, very important to think about. Amy, I'm glad. Who is it? Chad said you never thought about it like that. What, like what? The coat hanger?
That's such a good analogy.
It works, and that's how I was taught it.
That makes
But
a
it
lot
works.
of sense.
It never left me.
So you guys will see.
It never left me.
You guys will see when we get into the sort of application training, which is the device training. You'll see there's obviously different depth and frequencies and presets and so on. That you can kind of work through, and then this is where this will sort of start making sense a little bit more, because all those settings, as soon as you get a grasp for them and understand them, you can actually, you like an artist then, and you can like Joe said, it can disappear or it can be visible based on your settings. You can literally look past something that's right there and not see it because your settings are wrong. So yeah, I think it's very important to. These are like the foundational things. I mean, it took me a long time to understand. I still didn't understand all of it, but again, because I'm not a clinician anymore, so I'm not scanning. But it took me a while to understand some of these concepts.
Yeah, the concepts are important. Once you understand the concept, you can build on the foundation. But don't try to scan and not understand the concepts. 1 second. Okay. So there's a couple of other things that we need to do conception-wise, and I'm going to let you guys go after we go through the concept, because this is like very heavy material. The rest, I promise you, the next couple of lectures will be fun. There'll be anatomy. There'll be things that you as doctors can relate to, but this concept is important. What I would advise you to do is to actually learn the concept and try to memorize the concept. The ones that you don't have to memorize, leave them alone because they will come later. Okay, there's a couple of different information that our ultrasound machine will use to give us the image and basically how we manipulate the image. Remember I said that most of the imaging is done on receiving, right? Most of the images is done on receiving. We send the wave out. It takes a second to leave that transducer, but when it comes back, it brings back a lot of information based on what it just saw, okay? Number one, the brightness levels. The brightness levels are separated into millions of dots on your screen. So if you look at your screen, once we get to that stage, the brightness on your screen are made up by millions of dots. Just like your TV, just like the monitor in your car, all those brightness are just millions of dots, and each dot corresponds to a different echo. Each dot corresponds to a different part of the anatomy that you're going to be seeing, which provides very valuable information, right? The electrical signal, we said, that's generated in the ultrasound machines forms the basis of the image construction, which is why if you're working with a corded system, you're using cords to bring information back and forth. If you're using a wireless system, you're using wireless, whether it's Bluetooth or whatever, to bring things back and forth, you have to be careful about your display also, right? We already talked about your echo dots or returning dots. Travel time is very important. The location of each of those dots on that screen is related to how long it took to get back to you, right? This timing is very crucial because how long it takes to get back to you can actually distort your image. There is something called an artifact, right? Artifact in ultrasounds are things that are not really there. It's kind of like, I don't know, when you're looking at the sun through your sunglasses and you see those rings that are in your sunglasses, or you're driving at night, that's a better example, and you look at the traffic lights and your eyes are not what they used to be and you have those rings, those are not really there, they're artifacts. And sometimes artifacts end up on our images because of travel time. I'll give you an example. The speed of sound through certain things is a constant. We'll get there in a second, right? And your machine knows that the speed of sound is 1540 meters per second. However, if that thing is bouncing back to you and it interferes, it hits interference on the way back, and it takes longer than 1540 seconds to get there, the machine doesn't know that. And it's going to assign that dot a different distance based on what just happened. So basically, these artifacts come up. One of the other artifacts that we talk about is shadowing. You image a gallstone, and people like Muhammad that have been imaging for a while know this. When you image a gallstone, you get nothing behind it. There's no sound that penetrates it, and nothing comes back to you. The sound, everything comes back to you, nothing goes behind it. So imaging artifacts are things that are not really there. Okay, we'll hit that actually when we talk about Shadrach. When Shadrach gives you his abdominal lecture, he's going to go through a lot of the imaging artifacts that you can get when you hit gas, when you hit stones, when you hit air, things like, and when you hit solid bone, okay? Tissue velocity, okay? The tissue velocity basically is what we just said, 1540 meters per second. This is another number you need to remember. Remember I said, don't write things down, but this number you need to write down, 1540. That is the velocity, the sound, okay? The standard sound of sound that as it passes through soft tissue. And soft tissue is an average, right? Liver, kidney, spleen, all have different velocity, but we average them all together and get 1540 meters per second. This is the standardization calculation of speed of sound through average tissue. We need to know that because certain calculations that you would have done in the old days, I remember in the old days, they made us calculate a lot of things, Doppler signals, things like that. Now your machine automatically does it. You don't have to do it anymore, okay? And lastly, the image formation process is something that you're going to become familiar with. The entire process of how that image is put together after it comes back to you. What does the electrical signals do? What does the echoes do? We're going to become intimately familiar with that as you learn to scan, but it's not something that you need to memorize now. Just need to pay attention and make sure that as the image is coming back to you, when Chad and his team and whoever goes through the actual applications, we're going to teach you how to manipulate that image when it comes back. So that's going to be something that you probably do need to remember at some point. Okay. one of the things we need to do is understand how, and I hinted at it before, how does the sound interact with the tissue that it passes through or reflects back from? And I think I just gave you the answer. Either it passes through it or reflects back, or a combination of both. And that's how you get your images, right? So we're going to explore a little bit of what we call acoustic impedance. What does that mean? And remember, I said sometimes you don't need to know a lot. You just need to know the dictionary definition of the word. What does it mean when I say something is impeded? When I say something is impeded, it means that it was slowed down. It was stopped, right? It had to alter its natural course. If I run, and I've done this before, don't laugh at me, like I remember going through a mall, and you're walking in the mall and you get ready to go into the store, but they've polished the glass in that door so high that you can't see it, and you bounce off the glass, right? That's impedance. That glass impeded my progress into the store. It also works with sound. Acoustic impedance is what happens when sound does not want to go through something because that thing is hampered by density. Density is what causes acoustic impedance. It determines how fast, how slow, how echoey that sound is determined by the density, right? So something that is dense versus something that is not dense is going to have a different impedance factor. And you do not have to remember anything about impedance factor. No one's ever going to ask you to calculate that. All we need you to know is that density affects impedance. That's it. Okay, signal reflection is crucial for imaging. If there is no reflection of signal, there is no image. And I can tell you how this happens. If you look at somebody's bladder, those of you who are used to imaging, and you see either bladder or amniotic fluid, you'll notice that bladder and amniotic fluid, if there's no tumors, or if there's no meconium in the fluid, or if there's no vernix floating around the fluid, it's completely black. What completely black means in ultrasound is the sound ran away from you. It did not come back. It brought no information back, right? So it's kind of like, opening the door and letting a parrot out. It won't come back, right? That basically is called anechoic. When you see something that's anechoic, it means it has no reflection. It didn't come back to you. And without echoic sound, right? There's no sound. It didn't come back. So signal reflection is very crucial for images. It enables the visualization of the internal structures. The better reflection I have, the more I can see. However, we can also go the other direction too, where you get too much of a reflection, like against solid bone, and you can't see anything. So you need to be someplace in the middle, okay? The greater the difference in acoustic impedance, it enhances the reflection. So stronger signals, right, are impedance mismatches. So if I have two tissues together, such as the diaphragm and the liver, you notice that you're going to get a really nice picture when you image the diaphragm and the liver. And that's because the diaphragm and the liver have two totally different impedance factors. And whenever you put those two things together, you get a really lovely picture. Reflection occurs at the interfaces of these two things. Okay, so this is one of the reasons I drew these diagrams, or I can't take responsibility. My team put these diagrams together so that when you are out in the field and you feel you need to remember these things, you can have little cheat sheets going on. And also what I'm telling you also is that the things that I'm going over are essential if any of you are going to sit for your foundation of POCUS physics boards. These are all on the boards. These are things that you'll probably have, not probably, definitely have to know.
Sorry, can I interrupt and ask a question?
Absolutely.
Can you just explain that again, please?
Which one? Tell me which one.
Like the anechoic, the whole reflection thing you were saying about, I don't understand exactly you were saying about the diaphragm and the liver.
Perfect, thank you. And I'm glad you had that question. Okay, so let's take sound. Okay, let's pretend that sound is a tennis ball. Okay, and I'm taking that tennis ball and I'm throwing it into nothing, right? I go to my back door and there's a wide open, I'm in Kruger Farm, in Kruger Park, right? And I go to my lodge and I take the tennis ball and I throw it. That sound, which is that tennis ball, is never going to bounce back to me. because it has nothing to bounce back against. It has one impedance speed. It has one speed. It's going to keep going because it doesn't hit anything to bounce back. However, let's reverse that. If I take that tennis ball and I throw it and it hits a tree, right? That tree is such a different impedance factor than the air that it's going through that it will bounce back to me with a great force, okay? So keep that in your mind. Then let's say that I took that ball, that same tennis ball, and threw it again, and I hit a wall of water. That water still has different impedance, but it's just not dense enough for that sound to come back to me. The impedance difference is just not enough for that sound to come back to me. What I'm saying by that is the greater the impedance, okay, the better the reflection of that sound that's going to come back to you. And the better the reflection, the better the image that you're going to get. This is why when you're imaging the liver, you get such a beautiful picture. Well, unless the person is cirrhotic, you get a really beautiful picture because the liver borders the diaphragm. The sound is going to go through the liver, hit the diaphragm and say, wait a minute, I can't go any further because the diaphragm is not allowing me to go through. It's going to come back, but on the way back, it's going to give you pictures of the diaphragm, the liver, the gallbladder, the hepatic vessels, the arteries that are in the liver, probably the CBD, all the way back to you. So all those factors influence the picture that you get back. Am I a little bit clearer than when I started?
Yes, thanks. That makes so much sense. Thank you.
Okay, cool. I like breaking things down so that they make sense because sometimes, we think we're not physicists. I actually met Dr. Kremkal, who's the person that wrote the original ultrasound physics book. And I was like, he was a normal guy, but when he spoke, nobody understood what he was saying because he was a physicist. So I like to just break it down into tennis balls and water. I hope that works. Okay. So comparatively speaking, and this is just going a little above what you need to know, but I wanted to give you just an example. Understanding acoustic impedance in tissues is important because you have to understand that certain tissues have higher impedance than others. For instance, the diaphragm has a very, very high impedance. Things don't get through the diaphragm very well. So you see it very, very well when the sound bounces back. So if you look at this chart, you'll notice that air has almost no impedance. Sound in air is going to keep traveling. But the problem with air is that the molecules are so scattered that you won't get any reflection back. And the reflection you get back is not going to make sense. It's going to give you very distorted images and very high reflectors. And it's going to give you gas and what we call comet tails. There's going to be so much artifact in there that you can't read the image because sound in air, especially when it's trapped in a body, does not behave very well. Fat, adipose, also does not behave very well. However, the liver, when it's bordered against the diaphragm, will give you a good picture, as you see here. Bone is on the other end of it. Bone is all the way up, where if you hit bone, all the sound bounces back, right? Nothing went through, and you'll just get a big, bright line as it comes back to you. So sound does not travel through bone very well either. This just gives you an idea of the certain impedance factors of sound as it plays around. So basically, it's the interactions that we're looking for, right? It's the interactions. And I think nature is made up that way. If you're a chemist, you depend on the interactions between certain chemicals. If you're a physicist, you depend on the interactions between, the geographical forces, things like that, gravity. You depend on that. If a car is, this is why you have, car accidents. This is why people test cars, because if a car hits a wall, all that energy is transferred someplace. It has to go someplace, right? And that is interaction. So understanding ultrasound waves are also understanding interactions. Exploring the fundamental interactions of ultrasound waves helps us understand how we do medical images. So there's a couple of things that we need to know, a couple of phrases we need to actually belong to and embrace them and have them belong to us and start using them in our day-to-day language. And luckily, light and sound behave almost identical. They do. There's some differences, but a lot of the basis of light and sound behaves identical. So number one is reflection. We know that reflection occurs when something bounces off something. and it comes back. So with sound, reflection occurs when ultrasound waves bounce off surfaces, allowing the creation of images from different tissues and different structures and different interfaces. Remember, if nothing reflects, you don't have a picture, right? If you don't have a reflection, you do not have an ultrasound image, right? So sometimes maybe when you don't get an image, ask yourself why. Nothing reflected. You're going through amniotic fluid. You're going through somebody's bladder. You're going through a cyst. There's really no reflection. There's too much fluid. It doesn't come back to you, okay? Attenuation. When something's attenuated, it means the direction has changed a little bit, right? It basically, attenuation refers to the reduction in intensity of ultrasound waves as they pass through a tissue, right? They impact the image quality, right? The reduction of intensity. So basically, if you think about it this way, if I bring it down to ground level, if I start running, let's say I'm running a 5K, right? I start running and I'm running at a certain kilometer per hour. Do you think I can keep that as a human being? I can't keep that speed up forever. So if I have to run through mud, right? That mud is going to attenuate my speed. It's going to slow me down. I'm going to lose intensity. If I run through water, it's going to slow me down. I'm going to lose intensity. Sound is attenuated when it moves through something. If it moves through tissue, it's attenuated. It slows down, right? Because it loses energy. Initially, it's 1540, but it can't keep that up forever depending on the tissue. Refraction basically is the bending of that wave. And how we see that is if you drop a stone in water, that stone does not fall. I mean, unless it's like, tons, it does not fall all the way down in a straight line. It's refracted a little bit because there's a change in the surroundings. It went from air to water and it slowed down and it changed angles. So refraction basically is what happens when there's a bending of the wave as they pass through different media, and it influences the angle and the speed of the wave. Let me explain this to you. That same tennis ball that I was using in Kruger, let's say that I could actually stand a wave of water up vertically. And I took that tennis ball and I threw it from the air and it hit the water. Do you think it would still keep going at that same straight line? No, that line would now drop because it has been forced to lose energy and now that angle has decreased. That doesn't mean that much. Refraction doesn't mean that much until you start talking about like doing needle biopsies and things like that. And as we start doing more and more vascular interventions and things like that, it becomes like when you put your needle in, why is your needle at the same angle as when you put it in? We used to use, when I was teaching residents, we used to actually teach them to do amniocentesis by using chicken breasts and little balloons that they could put the needle in. And they all noticed that the needle always changed directions a little bit when it hit the liquid from the solid. That's called refraction. And then transmission involves the sound that actually passes through the tissue, right? Which is crucial for accepting the depth of the structure of organs, but sometimes transmitted sound is not reflected. And remember, we said that the only image that we get is from the reflected image, okay? So reflection, attenuation, refraction, transmission. Basic things that we're going to need to know how and when they work and what's going on, why we didn't get a good image back. Let's talk about reflection and refraction just a little bit before we end. I won't keep you too long after this, right? An overview of how it interacts. So ultrasound reflection is basically when the waves reflect off a tissue to return to the transducer and it creates an image. This is just a review. We've already spoken about this. The important characteristics of that image, right, depends on the strength of the reflection, right? Different tissues reflect ultrasound waves differently. Bone reflects differently than your gallbladder wall. Your gallbladder wall reflects differently than a baby's femur. Baby's femur reflects differently than the intima layer of a vessel, right? So we start to learn after a while of doing these things. We learn the reflections. We learn the reflection patterns. I know now after 35 years, when I'm seeing a certain reflector, I know that's got to be a bone. That's got to be a baby's femur. That's got to be an occipital socket of a baby, or that's got to be the cerebellum. So it's the reflectors that give me that clue, okay? Sometimes, Chad, I think that you and I need to teach med school on a different, in our next life. Okay, so the rule of acoustic impedance, we already talked about impedance, and impedance basically just means what? The degree of reflection varies basically based on the differences in the impedance of tissues. So as I'm reflecting back, it all depends on what that acoustic impedance is. Let me explain it. If you have an acoustic impedance of 0, there is no impedance at all. That means that, right, that sound, there's nothing to impede it. It's just going to keep going, right? At that point, do you think you're going to have an image? Absolutely not, right? There will be no reflection. If there's nothing to impede me, I'm going to keep going. I had a little dog once, and in fact, actually my first dog, we found it, I think I was like 9 years old. And we found it on the street, but it was always wanting to escape. It was like forever astray. And one day the gate opened and that dog shot out of the gate and we never saw him again. He had 0 impedance, 0, right? So impedance means that the greater I have my impedance, right, the more my reflector. The lower my impedance, the less my reflector. Okay, something for you to remember. It's not going to be on a test. It's just a fun thing to know. The formation of ultrasound images, though, like I said before, depends on reflected echoes. The more reflected echoes I get, the better my image to a point. But if I go over that, then I'm hitting bone. I'm still not going to get a good image. So I have to be someplace in that middle. The optimal tissue for imaging, they always say, is the liver, because the liver has just the right amount of impedance and just the right amount of reflection in order to see an image, okay? So refraction, basically, and this is something that, again, don't spend too much time on. Refraction affects the ultrasound direction. We don't want too much refraction because, remember, our probe is at a certain point. If it refracts, then we're going to lose our reflection. If the sound bends and changes too much, then the sound won't make it back to the probe. So basically, it's going to affect the transmission of the ultrasound wave. Some waves penetrate deeper into the body and they continue the path through tissue, reflecting off deeper surfaces, which essentially is sometimes not good for getting images back. So imagine if the sound is going, it's going through the liver, it hits a calcification of the liver, it refracts, but on its way back to the ultrasound transducer, it just never makes it. It never gets back. It goes off in a different direction. And in actuality, more sound is lost than we get back from our ultrasound machine. So basically the role of ultrasound in diagnostics, basically it's going to utilize the principles of refraction, transmission, reflection. All that is going to come together to give you the image that you should have. Now, we already said that sound has different speeds in different media depending on what it's going through. And it just makes sense. In soft tissue, it was 1350, right? However, in air, sound goes at 330. In regular tissue, it's around 1040. In bone, if it could get through the bone, it would be about 4030, right? And this is just things that Shadrach thought, he's our instructor, thought that you should know. Nobody's going to ask you for this. It's just incidentally things that kind of, I always call them trivia, basically, but the speed of sound through different media. If those of you who are going to go on to take your ARDMS, if you were going to take your medical sonologist test, you'd have to know how to calculate this stuff, which I don't even want to think about. But anyway, so really basically, and we're almost to the end now, to break down our frequency ranges of our regular transducers, and this is where we're going to pick up with abdominal scanning next time, right? To break down these frequencies. Now, if you're looking at the range of regular frequencies that you're going to be scanning with in your regular transducers, you're going to be going anywhere from a 2.5 megahertz to a 5 megahertz transducer. This is what I use for just regular, everyday obstetrics, abdominal, EFAST scan, things like that, right? With a mom that's really, thin or slender, I'm going to use probably between a 3.5 and a 5.0 megahertz probe. With a mom that's a little larger, or she's in her third trimester of pregnancy, I might drop it down to a 2.5 megahertz probe. But I would never go above a 5 for an abdominal, or unless you're doing, like a newborn or something like that. Usually I keep it in this range. Now, the higher frequencies I use for different things like a breast, thyroid, testicles, soft tissue mass. If I'm doing like a soft tissue injection or a soft tissue aspiration or something like that, I would use anywhere from a 7 to a 15. Now, 15s I usually reserve for very, very surface things, very surface things. If I'm, injecting a needle right under the skin, I may use a 15 megahertz transducer. But for, like, let's say my carotid scans, right? If I'm doing carotid, or if I'm doing, let's say, deep vein thrombosis scans in the upper extremities of a normal person, I would start off at a 7.5, right? And then I would move up to 10 to 15, depending on the size of the person. My higher frequencies, I'm going to use for more superficial. My lower frequencies, I'm going to use for deeper. Okay, and then something really quickly, and this is just review on artifacts. We're going to go through more artifacts. I didn't want to do artifacts by themselves because I want you to understand what they look like. But basically, this is just telling you that artifacts basically are things that are not real. They're a misreading, they're a misinterpretation based on either something you and I did as scanners, or something the machine is doing because we're giving it the wrong information. Artifacts in ultrasound can lead to really bad interpretations. I've seen people say that they're twins when they weren't, because we got something called a mirror image artifact, right? I've seen somebody say that they're gallstones when it was just a gas bubble floating around. So just really, really be careful as we teach you, and as we basically give your hands-on, basically the hands-on scanning will teach you how to avoid certain artifacts. And I think the thing is, if you can learn this with the hands-on scanning, it's so beneficial that when you're by yourself, you can recognize that, no, that is not two bladders. It's a mirror image artifact caused by the fact that the ultrasound has hit the reflector twice. And basically, that's basically what it is. A mirror image artifact is when the sound goes out, it hits a boundary, it comes back, but it doesn't make it back to the transducer. It hits another boundary. And now you think that there are two boundaries because it's giving you wrong information. This is when you start moving your probe around and getting different scanning angles. And then ending up with the planes of the transducer. And we're going to end there for the night, the planes of the transducer. There are a couple of planes that you need to know, and we'll go through this when we're actually helping you scan. And those of you who already scanned know this. There is a longitudinal plane, there is a transverse plane, okay? If you're holding the transducer, remember the transducer is cutting like a CAT scan. It's the same technology, the same kind of technology. When a CAT scan slices through, you tell it how many slices. I say, I want a 15 slice scan, I want a 32 slice scan. And what it does is it slices as I go in millimeters. Ultrasound does the same thing, only now it's controlled by you instead of a computer. And so it's like slicing a piece of bread. If I'm taking a piece of bread and slicing it the way it's sliced in Spar or Woolies, that is basically a transverse. It's taking something and slicing it and giving me a cross-sectional image, allowing for visualization in the transverse plane. We can then go to the longitudinal plane just by turning the transducer, and it displays the image along the length of the body instead of the transverse plane. The importance of that is you have to know that if you're looking at kidneys versus looking at the aorta, when you turn one on the other, you're going to get different images depending on how you're slicing it, right? Depending on how you're slicing that image, whether it's transverse or longitudinal, it's going to look totally different. So this is something to keep in mind as we actually start scanning and actually you start turning the transducer back and forth. And it also gives you a very good appreciation of those of you who are going to be doing fetal scanning, because when fetal scanning, you're not sure of anything because the baby's always moving. If I'm doing, like, let's say a longitudinal of the IVC, it's always going to be in the same plane, whether I go longitudinal or transverse. It's going to look One is going to look longitudinal, one is going to look transverse. However, when you're doing fetuses, it all depends on how the fetus is laying. So it gives you a little bit more of a challenge. So we're going to end there for the night. I'm going to open it up for any questions you either want to type or ask me. But as we move on, we're going to be getting more and more into the actual physics as we talk about the actual anatomy and physiology of scanning. But I wanted to give you a basis. I need to give you a springboard of where to start off so that when Shadrach next week talks about abdominal scannings and when Molly talks about obstetrics, that you have a basis to understand what they're talking about before you actually start doing it. So we're going to end it there. Any questions, please ask. Is it possible to get lecture notes before our next lecture on Thursday? It'll be super helpful. Absolutely. We can send these out, no problem.
What are we gonna do about the LMS? So basically, yeah. So you guys all know we've been talking about this bloody LMS for the longest time. So it was built by between us and Joe and the team as sort of our primary thing that we want to use for access to all the materials and stuff. So the sign-in and the logins, I think Cindy sent out a link for you to change your password and username and stuff, so that it's yours. And then the material and the videos and all of that stuff is to be hosted, or it's to be housed on or in the LMS. So we have had one or two technical frustrations, but yeah, I think that's Joe. We're probably gonna primarily be running it via the LMS.
Yeah, I mean, what we can also do, Chad, is we can do it two ways. We can load it on the LMS, or we can send out I think, is this PDF?
Yeah,
I think this is PDF. Yeah, we can send those out too, easy.
So Cindy can just then send it through to everyone. But then we're hoping that the LMS will be the primary channel.
Yeah, it will definitely.
Yeah.
Yeah, it's just a matter, guys, of loading. The LMS basically is a system. It's like a school building. You build the walls, but then you have to actually put the content within the walls, and that's what our challenge has been, is just uploading the context in the way that the LMS understands it. But we will get it right, trust me.
I didn't even know this. They're saying, I noticed each course was uploaded twice on the LMS. So see, even that's like a little small glitch on our side.
Well, thanks for telling me that. I didn't know that.
I'm assuming that's the clinical stuff, because the business course stuff and the videos are less. It's a lot less in total.
So Chad, somebody wrote on the chat, thanks for the lecture, so excited to go deeper. Imagine if med school was fun like this.
That's awesome. No, it's awesome. It's awesome. No, Karina, thank you for mentioning that about the LMS. It's very
I'll check that.
Yeah. But yeah, it will just be this, because there's a bunch of short little tests and quizzes and stuff as you guys go through it over the next few weeks. But yeah, it is a different way of training, and I'm glad you guys enjoyed it. Any other comments or thoughts? Yeah, please pop it in the chat. Joe, I don't know if there's anything else from your side that you want to add.
No, I just want to add that this is very exciting for us to be able to do this, guys. I mean, we're looking forward to see what you guys are going to take this to. Definitely.
Joe, Karina just asking which to do first. We'll just I think we'll just have to relook, Joe, why it's twice, but its fundamentals should be the first thing, I guess.
Yes.
But we must just double
let me I'll get on with IT first thing in the morning and check and see what happened. But I have a feeling it has to do with stuff we were talking about, Chad, like the formats and stuff like that.
Yeah, for sure. No, cool, guys. So then I think that's us for the night. I'm super happy you guys enjoyed it. I enjoyed it. This is the first of many to come. You guys did receive all the links and stuff quite in advance for each session. So we'll try and do as many we'll try and do as many as we can with you guys now, like hands-on, and Joe's going to be involved with quite a few of them. So
Yes.
yeah, that's where we are.
Perfect. All right,
Joe,
guys, go get some rest.
I think Joe, you might just have a look at some of the comments about the LMS. So like, Bianca's saying, it seems like it's on night mode. Or to read some of the text. Okay, cool.
Okay.
No, this is good. Thank you. Yeah, we don't. It doesn't always come up like that when we upload it. So yeah, it's good.
Yeah,
Joe.
because there's you know what it is. There's an instructor mode and a student mode, and I'm not usually in the student mode. The instructor mode looks a lot different. So what I may do tomorrow is just before I call IT is actually go into the student mode to look and see what it looks like, and then have IT fix that real time. But you guys are also the first. So by the time the second cohort gets here, it'll be perfected.
Exactly. Just another question: is there a guideline or pace at which we should be going through the modules to ensure we're on track?
Is there a guideline or a pace? I didn't think that I gave the modules a guideline, but I can do that. Because the thing is, I hated to basically bombard people with timelines, but I can definitely do that. Let me go back to our instructor and ask him to just assign it a guideline, just assign it a timetable, basically.
Because it's basically 3 weeks of
right.
Got 3 weeks to go through this, and in the 3 weeks, we're also going to include the virtual care one, which won't be as intense as this. That will be like one session, and it is quite a lot on for the clinical stuff. But we basically have 3 weeks, and then in the fourth week, we'll be doing the 3 days of scanning, and thereafter you're sort of ready to go. So
100%.
over the next 3 weeks, it's gonna be a combination of the focus stuff, filling in some of the gaps on the business, doing some of the registrations, company registrations, all those ancillary things that make up this. But yeah, it should be about 3 weeks of clinical time. Like 3 weeks, you should give yourself.
Perfect.
But yeah, if I'm just glad it was fruitful for you guys, and we're also learning as we go. We don't know everything. We really appreciate any input and feedback you guys do give us. But for us,
Chad, there's another question. If we have queries regarding the course, like if we miss a section, who can we email? Like, I guess that's the course in the webinar. Who can they email for that?
Yeah. So basically, again, we're gonna upload the videos onto the LMS so it will be there. But then, and obviously the course material will be on the LMS. I was hoping we'd be able to just use the LMS as a primary communication channel with the lab. So if anyone has any questions, and someone from your team, Joe, can maybe just respond to questions and stuff on the LMS.
Yes.
Or we could maybe give one of the instructors emails that they can then directly engage if there's specific questions.
You know what? To be honest with you, Chad, I mean, if they do, you can do email. They could do me. Because I usually know what's going on with the rest of instructors, and a lot of the instructors have their own practices, so they may not be able to get back, in time. So why don't we just make my email that point instructor email that they can ask questions and stuff too.
You really love this. The fact that you are like all in. That's amazing.
Hey man,
it's amazing to hear.
I wish that somebody would have done this when I was in school. I totally wish this.
Yeah. No, I get it. Cool, guys. Yeah. Any other comments, please? Yeah, we'd appreciate it. Good, bad, love to hear it. I think we'll wrap it up. If anyone does want to leave any positive thoughts or comments or anything in the chat, please do. It does help us a lot. And we appreciate all the constructive feedback. This was quite a cool session. I enjoyed it a lot. And the next one is, when's the next one, Joe?
Next one should be Thursday, I believe.
Thursday or Wednesday, I'm just double check. But yeah, everyone did get the timings. yeah, I really want the LMS to get sorted now. So Joe and I would get on with IT early in the morning, because
Yeah.
we built it specifically for this, basically. So it's yeah, we also teething a few teething issues. But yeah, I also love the analogies. It helps a lot. Yo. Like, even though I've been in this industry now for so many years and I've been working with, there's just sometimes people ask me things and you only really understand something well if you can explain it like a 5-year-old, and I can't explain it to a 5-year-old sometimes. And then Joe, obviously you've got a lot more knowledge, so it's just like, yeah, it's so nice to hear it in such a simplified manner. It's really cool.
Cool. Love that you guys loved it, man. It makes my job so much fun.
Yeah.
Cool.
All right, guys. Now we'll wrap it up there. Thank you so much. Have a good evening. Yeah, we'll try and get all the material and stuff to you guys ASAP. And then yeah, we'll probably see you guys all at the next session. There's still a few business related things I need to just sort out with you guys. Like, I wanted to follow up with you guys on how this last week went, and if you guys have managed to sign up and everything. But I'll do that. I'll do that on another. We're gonna do WhatsApp groups for each cohort. So we're breaking down each cohort into specific WhatsApp groups, and then we'll just use that as a channel for direct communication, because the emails get a bit lost between everything and everybody. So, all right, okay, thanks guys. Have a good evening. God bless you all, and we'll chat to you guys later in the week.
Good night.
Thanks, Joe. Cheers.